Good morning, respected Director Ma'am, Dean Ma'am, and all respected faculties present over here, and my senior and junior colleagues. Introduction. So the birth of a newborn baby is one of the most exciting events in a family. So one of the first questions that is usually asked is it a boy or a girl? But when a child is born with an ambiguous external genitalia, it often comes as a shock for the parents, and it becomes a diagnostic dilemma even for the treating physicians, like presenting a problem of sex assignment. And it is important for the clinicians to promptly make an accurate diagnosis and counsel parents on therapeutic options. And in the past, several names has been used like intersex, hermaphrodite, pseudo-hermaphrodite, or sex reversal. But all these terms are replaced by the terms disorders of sexual development, according to the consensus based on two societies like in European societies. And so now coming to our today's case discussion. So it's a 11 years male child, resident of Tehri, Garhwal, Uttarakhand, and Hindu by religion. Informant is mother and the child himself, which is reliable. And the chief complaints were like recurrent pain abdomen since 1 year, decreased appetite since 1 year, and non-palpable gonads noticed 1 year back at the age of 10 years. So birth history goes like he's a full term, normal vaginal delivery, birth weight 2.5 kgs, cried immediately after birth, breastfed, no history of any drug intake by the mother during pregnancy or maternal virilization. And coming to the postnatal period, at 3 weeks of age, like till 3 weeks of age, he had multiple episodes of vomiting and feed intolerance, for which he was admitted in the hospital and given IV antibiotics and IV fluids. Following till 5 months of age also he had these multiple episodes of vomiting and feed intolerance. Suspecting that, he underwent a surgical exploration for query malrotation, for which documents were not available, although in spite of the surgical intervention also he continued to have these multiple episodes of vomiting, feed intolerance, loose motions. So on further evaluation, he was diagnosed as a case of congenital adrenal hyperplasia by a pediatrician and started on tablet hydrocortisone and tablet fludrocortisone. Following after starting this medication, the child improved symptomatically from 1 to 10 years of age. Like he improved symptomatically. However, there were episodes of dizziness or episodes of loss of consciousness during fever or any loose stools. Patient
postnatal, neonatal,
like at birth, then after birth, these are the events like this happen till 10 years of age, ma'am.
It should be neonatal. Okay.
Patient was doing relatively well, was in his usual health during this 10 years. When her mother noticed about the absence of palpable gonads in the scrotum, and there was no history of any constipation, diarrhea, chronic cough, headache, or blurring of vision, no history of any cyclical hematuria, and on the sexual orientation of the patient is male only. He identifies himself as male. He likes to play with cars and sports like football and cricket. He has male friends and dresses like a boy. Coming to developmental history, he has delayed motor milestones. He achieved sitting at 6 months and walking without support at 2 years of age. Speech is normal, but at present all the milestones at 10 years of age, he achieved all milestones as per his age. The family history goes like there is a history of death of a newborn sibling at 1.5 months of age with similar complaints of loose stools and vomiting, and another younger sibling which is a healthy 6 years girl with no history of any virilization. The patient's father expired 3 years back due to coronary artery disease, and no family history of short stature, diabetes mellitus, hypertension, thyroid illness, or any other chronic illnesses. Coming to the general examination of the child, the weight is 31.5 kg, between 50th to 75th centile, height 145.1 centimeter, which lies between 75th to 90th centile, BMI of 14.96, and otherwise the vitals were within the normal limits. And he had generalized hyperpigmentation over the skin and buccal mucosa, no goiter. And coming to the local examination per se, specific local examination, as you can see in the picture, there is scrotal fusion, and bilateral gonads were not palpable. The meatus is at the tip of the glans, so no hypospadias. And the stretched penile length is 7 centimeter. And there is an external masculizing score which comes to 9/12. When you see it, the components of this score are scrotal fusion, micropenis, urethral meatus, and the right and left gonad. So we can see here, he had scrotal fusion, micropenis, and the urethral meatus. So the score total comes out to be 9 upon 12. And another scale that we use for virilization is the Prader scale. So in this scale also, like stage 1 comes to the normal female and stage 5 towards the normal male. So stage 1 to 5. So 1 is towards the female and 5 is towards the male. So he falls in the stage 5 category, where there is penile clitoris, urethral meatus at the tip of the phallus, scrotum-like labia, which appears more like male. And the systemic examination, all the systems like more or less are within the normal limits. And coming to the relevant investigations that we did for this child, the electrolytes were within the normal limits, and the ACTH, which was raised, like it was 312 picogram per milliliter, which was raised. The serum testosterone was mildly raised, like 541 nanogram per ml, and the blood sugar levels were within the normal limits, and the serum hydroxyprogesterone was raised, and we suggest like it can be a CH due to 21 hydroxylase deficiency enzyme. We got a karyotyping done for this child, which turned out to be 46XX. And to look for the gonads, we did a MRI abdomen and pelvis, which showed the bilateral ovaries, and there was bilateral ovaries and small uterus with empty scrotum. And he had been taking this steroids for a long time, and to ascertain the bone age of this child, we got a X-ray wrist of the X-ray of the hand done. So which suggests the epiphyses are fused in the metacarpal bones, suggesting the bone age to be more than 14 years. But on paper, the age of the child was 11 years. We suggest the precocious puberty, that because of the increased androgens and the steroids he was taking on. So the final diagnosis was made of disorders of sexual development 46XX with extreme virilization of Prader scale 5 due to the congenital adrenal hyperplasia with salt wasting 21 hydroxylase deficiency. This patient was managed in collaboration with the Pediatric Endocrinology and Department of Psychiatry. Then we got a reference from endocrinology for this gonadectomy. And then to further plan the management, we formed a local body meeting comprising of the Department of Pediatric Endocrinology, Department of Psychiatry, and Department of Pediatric Surgery to further plan the treatment course of this child. So after getting a consultation from Department of Psychiatry under Dr. Vijay Krishnan, we found out there had been the child was reared as a male. He wanted to be reared as a male, and there is no feature suggestive of gender dysphoria. And in this committee, a thorough discussion happened between the parents and the committee members, following which it was decided to continue rear him as a male and to go ahead with hysterectomy with bilateral salpingo-oophorectomy, and after this procedure we start on to give lifelong testosterone supplementation as he will be reared as a male further on. So then the patient, after taking informed consent from the mother and this local body committee, then the patient was planned for this surgical procedure, which was cystoscopy followed by robotic hysterectomy with bilateral salpingo-oophorectomy. Cystoscopy was done and it revealed there is no accessory opening, or the vaginal pouch was not opening into the urethra. And then we proceeded with our robotic hysterectomy. As you can see here, this is the right side adnexa showing the fallopian tube and the uterus. And the other side adnexa showing the the upper 1/3 of the vagina was amputated and sutured using vital sutures. And the final specimen was this, along the uterus, ovaries, and the fallopian tubes, and the upper 1/3 of the vagina has been the bilateral salpingo-oophorectomy with hysterectomy was done. And then the post-op it was uneventful. The patient was discharged on post-op day 3 and is under regular follow-up under Department of Pediatric Endocrinology for lifelong testosterone supplementation. And then coming to the discussion part, disorders of sexual differentiation or differences in sex development includes spectrum of disorders, which mostly comes with ambiguous genitalia, And although in the law, like although general neutral upbringing is like accepted in the legal system, but in our Indian socio-cultural milieu, like it is hardly accepted by the parents or the society. The reason for choosing this case for this forum, because the management of these complex cases require highly specialized pediatric care or pediatric surgical system. So where multidisciplinary team approach can be done, and these cases can be managed using different departments, and basically multidisciplinary team management required in managing all these cases. So there is a guidelines from Indian Association of Pediatric Surgeons, the DSD guidelines published in 2022. So these complex cases are to be managed in only those centers which can have a local multidisciplinary committee comprising of the pediatrician or at least a pediatrician or a pediatric endocrinologist, a pediatric surgeon, and a child psychiatrist or psychologist, or a pediatrician involving adolescent care. And in the cases which can be managed by the local multidisciplinary committee has to be taken up to the state multidisciplinary committee, which consists of these 3 members, and along with a geneticist and a medico-social worker. And at the apex is the apex multidisciplinary committee. The most complex cases have to be dealt by the apex multidisciplinary committee, which like involves the ministry level of ministries. And so now coming to the guidelines of the newborn, like any sick newborn born with ambiguous genitalia should be evaluated as an emergency basis for DSD, and any unexplained electrolyte imbalance with the history of loss of sibling, like in our case, in similar is strongly suggestive of a congenital adrenal hyperplasia. So when DSD is suspected, like it should be a multidisciplinary approach involving the pediatric surgeons, pediatrician or pediatric endocrinologist, at least at the level of local multidisciplinary committee. The aim of such a comprehensive meeting is to convey details about the suspected disorder and discuss the further line of management with the caretakers. And in the general principles that is followed in CAH is like normally the CAH patient, the karyotypic is 46XX karyotype. So female sex is mostly favored, because they have normal female internal genitalia, and they have a fertility potential also. But when the child present to us in a newborn period, mostly we prefer female sex. And if there is a mild clitoromegaly or Prader stage 1, 2, 3, 4, we can go ahead with feminizing genitoplasty. But as in our case, when the patient presented on a later stage, with extreme virilization, it becomes a difficult and challenging, it's confusing, and it becomes a controversial topic, like whether to go ahead with feminizing genitoplasty or to continue rearing him as a male, earlier if he has been given as a male gender. So the conclusion is this CH is one of the most common causes of ambiguous genitalia seen in about 95% of the cases. And CH in newborn females, mostly, like I said, female gender is preferred. So mostly feminizing genitoplasty is done. But in cases of delayed presentation, we should have a multidisciplinary approach management, and gender assignment should be solely based on patient's perceptions and preference of the family and the patient.